series here of Low Carb USA 2024. This time with Rob, Dr. Robert Cywes, the Carb Addiction doctor. We had Rob on a couple of months ago, but today I want to ask a different question. As the Carb Addiction doctor, mental health is something that you have focused on. I've noticed a huge emphasis on mental health and keto's impact. What's your reaction given from where you stand?
Well, there's no question that mental health and a ketogenic diet, or really mental illness and a high carbohydrate diet, are intimately related. You cannot separate the two out. And it is both in the formative era with the structure of the brain, and then also from an addiction perspective, it affects cognition. So both insulin as well as glucose affects the cellular brain function. For example, insulin regulates mitochondrial function in the brain. We know that. So people that have very high levels of insulin, people like me, fat people, obesogenic people, I gain weight very easily, we are at high risk for Alzheimer's. Now that's a brain issue. But then you look at the mental health space, and you can start at the lowest level of mental health space, which is dysfunctional stress management, which pretty much everybody, certainly in the US, struggles with at times. And we use carbohydrates not as a food, but we use them as a drug for instant gratification, for instant resolution of emotional stress, anxiety, stress, depression, anger, fear, frustration, boredom, exhaustion, and pleasure, emotional tension. And we develop instant gratification strategies to handle that. But then there's dysfunction on the back end. And the dysfunction is a profound erosion of our sense of self. Our self-confidence, our self-esteem, our self-respect is in the toilet because we have to justify using a drug that we know is not a good idea to ourselves, and we don't build up our sense of self. So we externalize our locus of validation, which is a big deal because we are not self-empowered.
Yeah.
And we rely on others, external substances, other people to validate on our behalf. That's carb addiction. Secondly, the drug itself, when used chronically and excessively based on your genetics, causes harm, whether it's diabetes, obesity, or the other diseases. And then the final thing is we become less effective as human beings because we don't problem solve. We get instant relief from the drug, but we take, I'm going to use a Latin word here, we take the shit that we're responding to and we shove it in our subconscious, I'll deal with you later, but later never happens. So I call that psychological hoarding. We take all the stuff that's causing us emotional tension, we get relief from the emotion, but we don't process the issue. You go for a walk. When I walk my dog, it relaxes me. Physical activity relaxes me, but it also allows me to connect with and process those tough emotional issues. So at a fundamental level, the commonest form of carbohydrate addiction is where we use it in a dysfunctional way to manage stress and other emotions. Now, when you level that up, some of those carbohydrates are intimately involved with a biochemical derangement in things like bipolar disorder. And that's just an exacerbation of very, very high mania, hypomania, mania, and then all the way down to deep depression. Everybody gets depressed, but some people just allow it to perseverate and don't have the chemistry in their brain or the wherewithal to be able to climb out of that hole of depression. A ketogenic diet stabilizes some of those metabolic processes. And while I'm very familiar with the science behind it, it's not part of my practice regimen, but the psychiatrist, Georgia Ede, brilliant, Chris Palmer, brilliant, and they will tell you that a deeply ketogenic diet is very valuable to stabilize these patients' mental health. Now, the part that I know of, that I'm not an expert in, it's more secondhand knowledge from these brilliant psychiatrists, both Harvard doctors, by the way, for what that's
really?
worth.
I didn't know that.
Yeah, Georgia and Chris are both Harvard doctors. But schizophrenia, they're treating that effectively and able to de-prescribe on a ketogenic diet. Now, those folks require deep ketosis. So we're seeing more.
We're talking major mental
in fact,
health.
Yeah, well, not only that, but also a carnivore diet for those folks is a little bit more appropriate because of the depth of ketosis they can achieve.
Yeah.
And then my passion as a pediatric surgeon is the structural brain abnormalities. And the commonest two that we see are ADHD and autism spectrum disorder. 1 in 20 children right now has autism spectrum disorder. And it is a structural abnormality of the brain caused by substrate deficiency, primarily fat in their diet. So when they're eating a lot of sugar and starch, the mother's eating a lot of sugar and starch, you get insulin resistance in the placenta, and then the same thing in the children. They don't get the substrate into their brains, and the white matter doesn't develop normally. So there's crosstalk problems. The gray cells work fine. The telephone works fine, but the wires don't connect. That's autism. Same thing with ADHD. I just did a video on this on my channel, where you've got these skinny, healthy-looking kids. They look okay from a distance, but you touch them, there's nothing there. There's skin, there's bone, there's no muscle. But the same is happening in their brain. So they've got ADHD, they're wired on sugar, they can't focus, they can't function, they need breaks all the time because they've got no emotion management support system. And those are young children that are going to live for 75, 80 years. See what our society is doing in that regard. Whereas you take a young child, you give them, they don't have to be on a ketogenic diet, but you give them meat, you give them fat, you add that to their diet, not just little lean chicken strips, but you get them to eat a carnivore-based diet. You can add in the vegetables, they can have crap, you're not going to deny the kid the cupcake.
Yeah.
But that should be ancillary to what they're doing. It shouldn't be the foundation of what they're doing.
The basic, yeah.
Their mental health is good, their physical structure is good, and they tend to be so much happier, so much calmer, and they're able to focus much more heavily on what a child is supposed to be doing, which is learning. And the mental health side, both in the organic diseases, the psychologic diseases, and just generally how we manage emotional tension, it is the foundation of that is in our diet and how we raise our kids.
You know, listening to you reminds me of an interview we did earlier today. Dr. Roshni, did you hear her presentation?
I did, yeah. I heard parts of it. I didn't hear the whole thing.
So it's a really, really good point. How often have you heard non-compliant patient? And
in our world, there's no such thing.
Yeah.
Okay.
So that's one of the key things. If you had like advice for your day-to-day family practitioner, primary care practitioner.
Well, let's make this personal. Let's make this personal, okay? Because as a surgeon, the person does well or poorly based on how good I am technically in the operating room. All they have to do is show up, and the result is based on what I do.
Yeah.
With what you and I do metabolically, we're giving patients advice, and everything happens because of what the patient does, not us.
Right.
And here's my philosophy. We disagree a little bit on the use of statins. You
Right.
like low-dose statins, I'm opposed to them. The most important fundamental thing is that the patient hears from me and they hear from you,
Right.
and these are smart people, and they make up their own mind. They've got the information, have information, and they then make an informed consent a decision about their own lives. That's not a if a patient of mine takes a statin because, you know what, I trust you, I like you, but I believe in what Dr. Brewer said, that's fine, I have no problem. I'm not going to, as long as I can say to them, you have the information, you make your own decision. And so there is no such thing as a non-compliant patient.
Yeah.
We choose
exactly
compliance.
right.
And you know what, if I say to you that you're fat, you're diabetic, you lost your toes because of diabetes, because of your relationship with sugar and starch, and they say to me, you know what, I don't care if I die. I can't help that person as long as they have the information. We can work with them.
That may not make them non-compliant.
Exactly right.
Everybody makes the assumption that it does.
Non-compliance is a choice.
Right.
Now, I have an issue with compliance of a parent to their child, because now you impact on another life.
Yeah.
That's where compliance comes in. And as a pediatric surgeon or a pediatric doctor that works with kids, that causes a lot of conflict, because they are now making second-hand decisions on poor information or using their own biases, non-medical biases, to raise another human being. And again, I don't want to get into the politics of that or anything else, but that is where I will call somebody non-compliant, quite happily. The mother doesn't get care for her child. But that is you taking somebody else's life. I am non-compliant if I don't provide as a practitioner, if I don't provide what I believe to be the most accurate information as I see it to my patients, so that they can make a decision.
So would this be an example? And if so, or maybe if so, if I'm a mother of a child, I bring the child in to see you, you evaluate the child and say, Mom, she's got some metabolic problems. We need to get her ketotic. And I don't listen. So how do you manage that?
Here's your can of worms. I took a Hippocratic oath. I don't know if you did. Okay?
I did.
You did. The Hippocratic, I mean, I don't know, different schools have them, different, some don't. But
It was a big thing for our school.
the Hippocratic Oath is something that I buy into very, very heavily. One caveat, but we won't talk about that one right now. And my Hippocratic Oath is to my patients. What's happened in healthcare is we've created often erroneous box called best practice guidelines. And the best practice guidelines are often erroneous.
Yeah.
So, and the
So true.
conflict right now is between my obligation to my patient with my experience, my knowledge of health physiologically, and best practice guidelines. And that is where the conflict comes in. So that's not a straightforward question. But if a patient comes in with appendicitis, baby's got appendicitis, and mom says, no, I'm not going to have you operate on the patient, that is a problem for me. If the mother herself says, look, I've got appendicitis, I'm consent giving age, I don't want you to operate, I know I might die, I desperately like to talk her out of it, but I can't force her to do that. But for her child, she has to make that decision. The problem when it comes to the information that's being provided is I feel very strongly about my knowledge base, but my knowledge base conflicts directly with the guidelines. Directly with the guidelines. And so where do we uphold this? And my ethics, my personal ethics as a human being and as a physician is to my patient. That's what I did with the Hippocratic Oath. And that brings me into conflict with those guidelines, and I've chosen to practice outside of those guidelines.
Well, I tell you what, you've got a further complication there when you're talking about kids, minors.
Absolutely. And that's why I didn't answer that question, because that's in the space that we work in, that's what we deal with. Although, there are very few patients or moms that intentionally want to hurt their kids.
Yeah.
We have a subset of those, but
that's rare.
It's rare, and it's a syndrome. But for the most part, they want the best. They may be misguided. There may be religious aspects to it. They may have been indoctrinated by certain words. But the biggest problem is that our society is wrong on this.
Yeah.
Our society is wrong on this.
On metabolic health.
On metabolic health.
Yeah.
And our society is driven very heavily by industry.
Yep.
And that's very concerning for me.
Big food, big pharma.
You know what's interesting? There's only 2 countries in the world that are allowed to advertise pharmaceuticals. United States of
Us
America,
and
New Zealand.
New Zealand.
For some reason. Nowhere else is it ethical to advertise medications.
Interesting.
Which is interesting because now you've got
really
all this biased narrative coming out.
Right.
And when a patient comes in demanding a medication, how many patients don't come and demand GLP-1s? It's challenging.
Best estimate, what portion?
I would say in my practice with my patients, probably not that many because of the metabolic nature of my practice. But I think overall, when I talk to colleagues of mine who work in the primary care space, every patient coming in there, I've got a toothache, will a GLP-1 work? They want GLP-1s for everybody. Yeah. Whereas the flip side is, if you go into a cardiologist's office, if you walk in and you have a pulse, even if it's 3D and in atrial fibrillation, no, it's not a very good. If you've got a pulse, that's an indication for a statin.
Yeah.
Okay.
Sure.
I've got a 0 CAC score. Every doctor tells me I've got a very high LDL. Always have. Oh, you must be on a statin, just in case.
And
I don't want to get into that side with you, but that's what we're dealing with.
A couple of points about that. I never recommended it for people with no plaque. Mm-hmm. The American Heart Association Standards Committee finally went that way. They don't recommend that either.
They don't. And in fact, the statements on the Agatston score says you don't have to be on a statin or an aspirin, actually.
You shouldn't.
But at the same time, you go to the doctors, they're still wedded to that idea. I'll give you another simple little data set. There have been 5 papers sponsored by the AAP, the American Academy of Pediatrics. Okay, they sponsored them involving a little bit over 100,000 children across these 5 studies, where they compared in kids under the age of 2 the consumption of skim milk and 1% milk versus 2% in whole milk. And they looked at obesity rates, they looked at allergy rates, and they looked at overall health. And in all 3 of those categories, the kids drinking 2% and whole milk were statistically significantly healthier on each one of those than and this was AAP sponsored studies. The AAP on the front page says every child should drink, I think it's 1 to 4 glasses of skim milk every day.
On the cover of those
on the first page or the second page of their website.
So did that come from Big Food?
It's called cognitive dissonance. It's called cognitive dissonance. They cannot believe that their own studies are correct. That's very challenging. Very challenging.
So that's one of the questions I've had for Eric Berg and several others. So given where we are today, what's the best way out? What's
The best
biggest
way out,
challenge,
well, the
and
best way
how do
out
we
is
deal with it?
exactly what we just talked about. Be informed. Go and see people if you can afford to, if you are engaged in this. Look up or watch people who are polar opposite in their views, and then go and do your independent physiologic research and decide for yourself which way you want to go. Make up your own mind based on the information. Okay?
That's a lot of work.
It's a lot of work, but you know what? Your life matters.
Your life matters, and you can't really depend on a medical system here to give you the right advice. When patients come to me and I can tell they've been doing that, I go, I just cringe because you can't.
Okay, guys, I have a question for you. I'm not putting that question. It's on the comments. Elbow macaroni. and you're gonna have a different answer for. So think who you want to answer this one first. So are statins bad?
Are
statins bad?
A lot of people think they are, and I think any kind of mid to high dose statins are bad. Rob?
Okay, so I'm going to answer that 100%, and I think you're going to agree with me. 100% of the time, statins are bad. They have a huge side effect profile. The issue is not whether they have a side effect profile, because they are bad. They cause you harm. The question is, to what degree do they actually help you, and is the degree to which they help you worth their side effects?
I think I would agree with that 100%. And the only time that I've seen that I would recommend them or have recommended would be low dose, very low dose statins, and only 2 statins, because it's like stuff like atorvastatin really doesn't accomplish what you want to accomplish. It does. What we're not looking to beat down LDL blood levels like the rest of the medical world is. We're just looking for cardiovascular inflammation management. And you don't need high-dose statins to do that. You get very, very few side effects comparatively for the low-dose statins. The other point to mention is that, as Rob was saying, you really don't need them unless you have plaque. And so many people have misunderstood that information.
So I would also tell you one other thing. If you are a physician, and this is going to be out there, if you are a physician and your first line of therapy for any patient is to write a script for a statin, I'm going to call that malpractice.
Yeah.
The first line of therapy
should.
I know, but you know what? I'm very comfortable defending it. The first order of business is a therapeutic carbohydrate restricted diet. You can write. Eric Westman writes a prescription for that, because without that, it's not going to work. You know, that's like writing a script for Chantix and telling someone, oh no, it's fine to keep smoking. It is crazy.
To your point, I forgot to mention this. Given what I do for a living, I have a lot of statin hesitant patients. And there are times when over half of the folks where I would say, I would usually recommend a low dose statin since you have plaque. Over half have said, no, I don't want to do that. Now, that's not the case right now. I'd say maybe 10%.
Right.
But I'm totally fine with that. And what the patient doesn't get, the patient's used to very paternalistic medicine, where the doc gets all wired up. And my perspective is, even if I were paternalistic, that wouldn't bother me, because you lose 30 pounds, that's 10 times more effective than any stent, any bypass, any medication, and any supplement, period.
I agree completely. So the foundation of treatment, always, whether you've got hypertension, you don't just write out this prescription for amlodipine. You talk to them about their lifestyle. Then they can choose. They can choose to take the medication. They can choose to do both. Right. The place where you and I are slightly at a difference of opinion, currently right now in, August of 2024, is that there are more effective, lower side effect medications to reduce plaque inflammation. But here's where you and I have consensus, is that it is no longer purely about cholesterol levels and LDL levels.
Correct.
It is more about inflammation. And
Not
what
at all.
methodology do you think is best to reduce inflammation? We now have aspirin. We have colchicine, FDA approved last year. So I look at HSCRP. I'm using low-dose colchicine a lot.
You're already using it?
Oh, I was using it before.
Okay. That's
and
interesting.
I look at uric acid
Very
and I look at HSCRP. And if they're elevated and you've got positive plaque, I will add low-dose colchicine. Because we're killing two birds.
Yeah,
we're killing
especially if you've got elevated uric
Correct, and it's not uncommon. We see that
No,
occur
it's not
now,
at all.
especially
That's
in
one of the
fructose
major
use. So,
drops.
yeah, so I start with the foundation of a therapeutic carbohydrate restricted diet or a proper human diet, whichever. I like all of those terms. And then if we need to add in anti-inflammatory medication for a while, we can decide which ones we need to use. And the three that I use currently are aspirin, colchicine, and GLP-1s.
Oh,
Those
you do?
are, yeah, those are the three that I am very comfortable using in combination, and really not for a long period of time, unless the aspirin I'll keep them on for a very long time, but until the inflammation goes away.
I am surprised to hear that. I thought you were very anti-medication for any type, especially
No.
especially with GLP-1s.
I've always been a proponent of GLP. I think GLP-1s in my lifetime are the single best medication to treat. They're the only medication that treats the disease that I practice against, which is insulin resistance.
Metabolic disease.
Insulin resistance
Insulin
specifically,
resistance.
which is the gateway to all metabolic disease.
Right.
Okay. So, and GLP-1 specifically target IR. The objection for me is same principle. All these doctors writing scripts for GLP-1. Here you go, eat less Oreo cookies.
Right.
It doesn't work. What I do is I put them on a ketogenic diet to the extent they can manage it, and then if they need something ancillary, either for disease severity or they're struggling, we add in the GLP-1s for a while.
You also bring up a point that I have to deal with every day. You know, when I do use GLP-1s too, and patients say, but I've heard that once you go on it, you know where I'm going.
Mm-hmm.
You can never come off. And it's like,
well, that's a
of
fallacy right there, because it's hormone. You get hormonal resistance.
Right.
So GLP-1s are a transient thing. Two comments about GLP-1s. The first thing, the majority of the side effects that are ascribed to GLP-1s, remember these are agonists.
Mm-hmm.
They aren't a drug. They're an agonist. Well, they are a drug, but they're an agonist of a hormone you already produce. They just make it
glucagon-like peptide.
correct. Agonist. So
Yep.
they make it work harder and more.
Mm-hmm.
But all of the gas bloat, the reflux, the delayed gastric emptying, the irritable bowel syndrome, the muscle wasting, that is all the drug is doing there is exposing an awful diet.
Yeah.
If you're not eating very much protein and your body needs protein, if you go below the threshold of protein your body needs, it's going to get it from your muscles. So your muscles waste. On my patients who eat a carnivore-based diet, 60+% of their diet is carnivore, they don't get the muscle wasting. If you don't eat carbohydrates, you don't get the GI effects. Because GLP-1, that's something we learned through the GLP-1s, is the primary trigger of acid reflux and heartburn. So if you're not doing the carbohydrates and you want to start that before you go on the GLP-1. But the GLP-1 is really there to correct insulin resistance. It's not a long-term medication. You don't take antibiotics forever. You don't take Chantix forever. You take it to get over the hump, and then
It's an adjunct.
Exactly
it's a
right.
helper when you need it.
It's a helper. It's an accelerant, an adjunct to what you're doing. And same thing with blood pressure. You're on blood pressure medication. Most people are on that for the rest of their life. With a GLP-1, you can stabilize your blood pressure and you can deprescribe.
We're taking a lot of people on blood pressure. We always have.
But you don't take them off. You don't take them off. They earn the right not to need the medication. See, there's a difference. I mean, we don't just stop the medication. That's an important point for me, because some people say, I'm going to go keto, I'm going to stop my blood pressure medication. No. You monitor your blood pressure, and when the numbers are good, you do the experiment of deprescription, but you change your diet first.
Now, you said something that may change our perspective, maybe another little difference between us. This thing about muscle wasting and GLP-1s. I'm not going to argue whether or not and how much it does. Part of me does argue with it and says, you get muscle wasting anytime you lose weight. And if you're losing
exactly
weight,
right.
especially down in the legs, because you're not
As a
carrying
bariatric surgeon, we see it a lot.
Yeah, you're not carrying a 40-pound fat vest.
Yeah.
And just try putting that 40
Just
pounds
squatting
back
the
on,
extra 40,
and do
yeah.
some walking and squatting and rucking with it. The thing that irritates me and that I go over with my patients is, if you're not exercising your muscles, why are we talking about it?
Protein just turns the liver to sugar and then to
Right.
fat if you are not triaging it to the muscles.
If you're
Absolutely,
not-
you're 100% right.
Okay.
100% right. And you know what? You don't have to, I hate the word exercise. Because when I was over 300 pounds, to ask me to exercise was ludicrous. Okay? But I use the word physical activity.
Yeah.
Because anybody can walk down to the mailbox. Well, most people can walk down to the mailbox. They may
Right.
not be able to go and run on a treadmill. To tell
Right.
me at 300 plus pounds to do 30 minutes of exercise was crazy.
Getting out of bed was exercise.
Getting out of bed, but what you do is you encourage movement,
Going
you
to the
encourage
mailbox
physical
is
activity.
exercise.
You go outside. Once you're outside, you're going to do something.
Right.
So you encourage the mentality of physical activity, and then as you lose weight, you can put more and more into that box. But if you don't have the carve out in your life to begin with, this is addiction coming full circle
Yeah,
here.
I've been sitting here
okay?
listening. That's
If
one of the
you don't-
reasons I like talking to you, because you've got such a perspective on the mental health and the addiction side. Some of this you've lived,
Right, of
and
course.
it's so much easier for you.
But it's my vision of it easy, and I've got to help my patients to understand what the replacement for the fridge and the pantry is in their lives as an emotion management strategy. And if physical activity is one of the components, you can be a thespian, you can be a fashionista, you can be into music, you can be into spirituality, meditate, I don't mind. But physical activity gives you the diversity, and the diversity prevents one from being excessive. So a diverse emotion management system that is effort-based is the healthiest way to live from a mental health perspective, irrespective of whether you just have a dysfunctional stress management issue or you've got a profound, serious psychiatric disease.
That was one of the biggest things that hit me out of this mental health series. Profound mental health diseases. I'd sort of heard of it before, but never really got deep. Like,
Doesn't it scare you? It scares me.
yeah,
It scares me, but you know
really
what?
does.
Every time I get scared of a lot of things, but every time I see somebody do it and be successful, I'm a little less scared.
Yeah,
Even in the advice I give to patients, I can't believe that you lost 300 or 200 pounds based on what I told you. But clearly that's evidence that we're right, because everybody else says I'm wrong.
yeah.
And that's a tough world for me to live in personally.
Now, when you say, does it scare you? Which part scares you? Somebody saying,
The advice I give to
okay,
people scares me.
take
Because
that a little bit further.
it's against the guidelines.
Oh,
And when CVS sends me a letter that's saying you are practicing outside of the guidelines because you did not prescribe a statin to a person on diabetic medication, that's problem. And I get those every day.
I'm sure you do.
Or your patient has cardiovascular disease, they're not an SGLT2 inhibitor, which is a terrible
Yeah.
drug for people on carbohydrates. Farxiga.
Yeah.
The reason they like Farxiga is because it doesn't raise the LDL. But
Yeah.
those are practice boxes, guidelines. Those are generic guidelines for everybody. But if you get bombarded with that information all the time,
Yeah.
you know, but
I
so
get
that
a
our
little of that.
results
I don't
prove
get
us.
much.
I've got terrible imposter syndrome. That's what it's about. It's how can I be right?
Also, again, in touch with yourself.
Well, it keeps you humble. I mean, it's there's
Yeah.
that self-doubt all the time. But that's also part of the addiction side. You never ever grow into someone that's super confident.
Interesting.
There'll always be self-doubt, and that's
So,
okay.
I've never shared this as a personal story. When I was in med school, I got a diagnosis of manic depressive bipolar disorder. And we talked about that several times today. I was always one that was able to basically keep it in check and manage it. And I used the energy from the manic stuff. And, people that knew me well said, oh,
Best
you're
state is hypomania. You got a lot done.
I stayed really hypomanic
Yeah.
more than anything else my whole life. And it was very interesting to hear the discussion about that today, because that's one of the things I noticed. When I went low carb, that hypomania just sort of grounded. It didn't decrease my energy,
Right.
but those episodes where you get so much energy, you have to struggle a little bit to control it.
Well,
Much easier.
one of the things when you get into ketosis, the way I describe it is, I'm not that good at sprinting anymore, but I'm really good at endurance.
Oh, really?
In terms of my focus, I'm not talking about that in a physical sense.
Okay.
I'm talking about it mentally.
Activity.
Yeah, I before the kind of almost ADHD thing, you could do a burst and do really well, but you get distracted very quickly.
Uh-huh.
Now I can do something for a very long time, focus for a very long time, and just that endurance stability, because my blood sugars are not doing this.
Yeah.
They're level.
Oh, yeah.
So it levels out. It changes your capacity to function as a human being.
Oh, immensely. Immensely.
So, and that's also mental health.
Isn't it? Well, this has been wonderful, Rob.
Oh,
Good to
thank
see you
Yeah,
again.
great to see you. We've got to stay in touch.
We do.
Good stuff.
Get in touch anytime you need anything from me.
I'll do that. No, it's been, and this gentleman over here, Jesus, behind the camera, we've always got to give a shout out to him.
He's the genius.
He
And
is.
I just go do what he tells me to do, except when I can't do it.
Can you repeat that back again?
There is such a massive group of Latin patients or Latin
Oh.
people out there that are heavily engaged and yet we're somewhat oblivious to them,
Oh.
which is such a sad thing. And the empowerment that a guy like Jesus and Ruben and a few of the other folks, Adrian,
Adrian.
Adrian has blown. I mean, that guy's brain.
Oh yeah.
It embarrasses me to even stand next to him. He's so smart.
We had lunch with Adrian yesterday. He gave us like an hour of good interview time. And we had dinner last night with a couple of folks that are common patients that you and I
Okay,
have,
okay,
Hispanic.
yeah.
And one of the discussions was low carb Mexico.
That's we spoke about that in Mexico City. Yes.
Yeah.
We hopefully will be there.
I think that's a big deal.
It is a huge deal. And you know, a shout out to Guillermo Navarrete in Miami. I just did some work with him last week. But the cool thing is, it's just the innovative. I know it sounds silly, but I would say something and then he'd rapidly translate into Spanish. And it was seamless. It was so good because he understood what we were talking about, added a certain context to it. That was exactly what I said, but in a context that resonated culturally
Yeah.
all over. I mean, you could see every South American flag popped up on that Instagram live. It was really cool. And I mean, the work that these folks are doing is absolutely incredible. Really, really good.
So Jesus announced yesterday that he's starting a Spanish language channel for us.
Perfect.
Right now is Dr. Brewer speaking Spanish. You cannot tell it's AI. But we're gonna do more than that.
Unless you watch the lips a bit.
Yeah. No,
And then
and that
it
I
becomes
think,
a little bit more clear.
you know, that's where Ruben and myself, we both have 3-year-old kids, to do a little thing with that, because there's so many people that are raising their children and don't understand or don't know how to do that effectively. So there's so many opportunities.
Is Ruben working with your channel?
I did one interview with him, similar one, where he spoke Spanish and I spoke English. But
Oh,
no,
he
he's not working
mentioned that.
directly with my channel.
Yeah.
But we have a very strong relationship, and I'd love for him to do well. The other person I want to give a shout out to is a woman by the name of Andrea Salcido. Andrea is a physician. She works up at Loma Linda. She is a gynecologist. She's a keto gynecologist. And she has just started out her own, she's gone out on her own now from Loma
Yeah.
Linda. She still works there.
Yeah.
But I refer
We
all my
met her
HRT
yesterday.
patients to her. She
Yeah.
is brilliant. She
Yeah.
understands the work. She's very science-based, but she's affable and obviously fluent in Spanish. So
Yes.
anybody from a Latino
point.
community or who is looking for hormone replacement or is looking for polycystic ovarian, infertility problems, any gynecologic issues, she's the one to consult, and you can now do it online. So I'm very supportive. This is all just in the Spanish community.
Excellent. I didn't know she was doing that online.
Yeah,
Just
she's
met
just
her.
started. I shoved and pushed. I feel like I feel like a little daddy to her, but it's so good. It's so good to see her flourish.
It is.
And she's brilliant. So I refer my gynecologic patients to her.
HRT patient.
Yeah.
Very good. Anything else? Anything
No,
we missed?
you mentioned the Spanish language side,
Yeah.
and the more we can support that, the better.
Oh, no question.
Yeah.
Thank you again, Rob.
Thank you. It's great.
Good to
Well,
see
see you in Cancun then.
We
See you
will.
in Cancun.